One last question before we open it up to other questions from the audience itself. Dr. Gulati, really quickly, you've been able to implement some interesting shared care practices as a part of your practice itself, right? If in a few sentences you could quickly describe it to the audience, and also what kind of outcomes you've been able to see.
Thanks, Prerak. I'll be very quick so the audience get their part. I think having worked in UK for 9 years, from where Dr. Kingston comes as well, and having working here for the last 5 years, I try to get something good from that system that we can implement here. So there, working as a consultant, we used to actually we used to interact with GPs with special interest in dermatology. So if I'm working as a consultant, then there are certain GPs or general practitioners who are working in the periphery and they have a special interest in dermatology. So certain patients, they can actually see their GPs for a few times before they come to us. So the number of visits to us reduce. So for example, if I'm giving some kind of a toxic medication for which I need blood monitoring every few days, then that can be done in the periphery by somebody who is actually able to do it. And then they can probably visit me only once in a while. So same what we are implementing here is you can't really actually do this with GPs here because the general practice standards are not to that extent. When we say general practice in India, it is MBBS. So at that level, we can't actually just leave the patient to them. So what we are trying to find is dermatologists who are in the periphery. So once a dermatologist goes into the periphery and settle, they usually they leave the academics to a great extent. So they're not following that. They don't have provisions for good diagnostic workup. So that is what we do for those patients. We come to a diagnosis, we implement the treatment, and then we say, you go to that particular dermatologist because he is very near to you or she is very near to you. So they can actually go there maybe monthly, and maybe just 4 to 6 months they can come back to me. So rather than coming from 500 kilometers every month, now they're coming in once, maybe 2 or 3 times a year. So that's kind of a shared care. And what that is doing is, it's actually giving the tertiary care to a person in the periphery with minimal expenditure. So I think that reduces the cost overall of reducing the tertiary care and reduces the burden on the tertiary hospitals as well.